we're going to move a little bit here from the practical ethics from what you might call theoretical ethics, talking about virtue ethics, consequentialism, deontology, principalism, and the ones that we didn't cover, situational ethics, natural law ethics, divine command theory. We could probably go on and such. What we're going to look at is that there are always particular ethics depending on what profession that you're practicing, and there's going to be things that are particular to that. That's so for nursing, it's so for engineering, it's true for, well, just basically any profession you want to get into. There's things that are particular to teaching that don't really exist outside of teaching. So ethics are typically, not always, but if you want to know the distinction between ethics and morality, morality is usually something that governs our actions. Ethics are just these principles that have been developed to sort of help regulate, our behavior within those particular professions. Those aren't definitions, just a distinction, I'd say. But what I wanted to make the point is that, we all find in the course of our careers that whatever morality that you and I had chosen to adopt for our personal ethics and may not necessarily be in conflict with our profession, but our profession is not going to ask as much of us as our own ethics may. All right, so in other words, the practical standards are going to be a little bit lower, and sometimes you're going to want to do more, and you're going to have to make a determination: am I in the right place to do this? So the book talked about perhaps how firefighters run into burning buildings. The average person does not, but it could be that if you were walking alongside and you saw smoke pouring out of a building, you might just want to go in because your morality tells you that this doesn't seem like I realize I can be harmed, perhaps die, but I see that young person up in the window and I've got to at least try. Nobody would fault you for not putting yourself in harm's way, but this heroic notion that's built off the morality you have may compel you to go farther than the practical ethics. So sometimes we're going to see, and we'll have some scenarios and stories where these two things are in conflict, and we're going to be looking at least today to perhaps not so much a heroic ordeal, but we're going to make sure that at the very least we're following the guidelines. So the ethical guidelines, the ANA, that's the minimum, right? So it's the least that's expected of you in the profession. All professions have some sort of governing ethics that monitors it. That's particular to that profession, and it's also the least that's expected. That being said, here's the deal. If you want to be great at what you do, you could probably go above and beyond. In other words, you know the difference between somebody who's just doing what they have to and somebody who genuinely, has passion for what they do. It doesn't mean that you need to love it every single day. We're not robots, and we have our own lives. And you're going to have your own families. Your kids are going to be sick. There's going to be problems with the house. Your relationship's going to be going sour, and you're going to think, how do I go in and put a smile on, right? Well, at those days, maybe you can rely on the minimum ethical standards because it's going to keep you not just out of legal trouble, but also it's going to help you be an ethical person. But then there's going to be spark moments, right, that just kind of hit you, and it almost makes the whole thing worth going on again. Teaching's like this, right? Teaching is a profession that's quite frankly a performative art. I mean, there's nothing systematic we can do. There's basic minimum standards that I should have with how I interact with my students and what the students expect from me. But, if you're just going to meet those ethical standards and nothing more, eventually either you're going to just turn sour and cynical or you're going to be not seen as a very effective individual. Just think of it in your own relationships, right? If you're with somebody, could you imagine that you're getting married to somebody and you went to them and said, I want a relationship to be healthy so that we never ever have to have fights or divorce. What's the least amount I need to do to make sure that doesn't happen? You can be like, well, you don't ask that kind of question. The minute you start asking what the minimum I need to do, you're already in the scenario that you're not going to do more than you have to. And at some point that's going to show up in your own particular professional ethics. Okay. So what we have then is we're going to talk in terms of these practical obligations that a person would have in nursing. A person could have this in engineering. A person could have this in education, right? And those then become the practical obligations based on the internal goods. So you think of the internal goods that you might have of empathy, of patient advocacy, of respect of that other individual as a person, and that they come first, their particular determination for what their care is. Those things are particular. In my field, there are some practical obligations that are based as internal goods. Now, internal goods as opposed to exterior goods. So we're not talking about, you perhaps going on to get your PA, or maybe you want to get a master's degree, and so that you can, dispense medication and have your own clinic, make more money. All those things are external goods. We're talking about what internal goods are necessary for you to function. And then there always are things that are particular to that profession. So for instance, like in education, it's also true in law enforcement and in even things like funeral directing. You're a mandatory reporter, right? So if a person was not an employed, say, professor or even just a high school teacher or elementary school teacher, if they saw somebody neglecting, or if a child came up to them and spoke about something that's happening at home, they could feel bad, they can ask some questions, but nothing is going to happen to them professionally because they're not in a position that they have to mandatory report. I would have no choice. If somebody came to me and was underage and said that this was happening to them by a teacher, the minute I got a name or anything, I have to call the Pennsylvania hotline. I have no choice. At that point, I could be legally culpable if anything comes of this. And even if somebody says I did not report. So if I went and told another professor, hey, here's what's happening, I've now a complicated situation by that person now has to report it too. So you don't investigate, those aren't part of it. That's minimum obligatory standards, right? There are things like that in everybody's profession. So the internal goods for nursing are going to help develop these particular practical obligations. What's expected of you when you're all done and you're in your position, right? They then will basically amass to what we can call an obligatory practical ethic. So whatever is required of you, of a nurse, they're going to determine that by internal goods that are expected for this profession, and they're also going to do it by just the practical obligations that you have. You can start out by saying about, showing up for your shift. And if it snows or rain, whatever, you can't get out, guess who's not going home? You stay there until somebody come in and replace. So it could be, a longer period of time. The shifts can be longer. Those types of things are all practical obligations. Your morality hopefully is higher for that, and you want to envelop those things within your morality, but even so, you have to at least do what's minimum. If there's something in your heart that you feel you can go further, that's entirely up to you. It might make you a great nurse, a great engineer, a great social worker, but it's not really required. So what you're going to have to do is find a way to mitigate your own morality standard with how this may work in your particular profession. Let me give you some examples so that it doesn't sound like we're just talking theoretical here, okay? It used to be that with an EMT, if there was a danger zone, it's like an active shooting, the EMTs would have to remain back in the staging area. And they would not allow any medical personnel into the school or wherever this was until they knew the active shooter had been either neutralized or was left. And what had happened in some of the school shootings, if you remember from back in the 80s and the 90s, is that you had teachers and students trying to get out the window and saying, we need help. And you can only imagine if you were the medical personnel that was back at the staging area and you saw this. I know me. I'm just too headstrong. I probably just ran in there and took what I can get, and I probably been looking for a new job when I was done. Your morality standards are probably going to start tugging on your heart and saying, I need to do something here. But you weren't allowed. Now things have changed. What they realize is these poor people, by the time they can neutralize, or at least make sure that the shooter was neutralized, they already bled to death because 3 hours went by. So they have new protocol in place. So my one friend who's also teaches, her husband was an EMT who literally was embedded in with the state police. So not too long ago in Pennsylvania, there was a shooting. I think the state police was either wounded or shot, and they were on a manhunt. So you know what it's like when you shoot a police officer. All the state is out looking for this individual, and they thought they had him in a particular couple acres of this one region. He was on the team that went right there with him. So they had trained, what they did was they figured we need to do something different here. So they took the EMTs and they trained them right alongside the state police, and the state police trained right alongside them so they can get a feel for each other. So he was right there in the hot zone, and how this would work, what he told me was that if they were in an active shooting, no longer do they stay back and wait for everything to be neutralized. They literally, unarmed, go right in, right alongside the police. And if the police and the EMTs are going down the hallway and there's someone laying on the ground that's injured, now I have no idea how this would work for other, I mean, who knows where an accident could happen, so I have no idea if this would implicate anybody in their future careers. But what happened is, then the EMT would stay there with the individual along with one of the armed officers. And he would just sit there and kind of scope the area while the EMT was taking care of them, and the rest of them moved on. And they just kept moving on like this, so you could see how it changed, right? So if somebody had, you know, maybe they were right with that moral implication that we need to do more than sit back here until this whole thing plays out, because people are dying. So just like practical ethics usually develops principles, because everything doesn't start out here and then filter down. It usually is the actions that happen on the ground that helps develop the principles, and they determine this is the new thing. All right, so now here's what we're going to do. But nonetheless, you know, if you're in that position, now that becomes your obligatory professional ethic. If a person says, I don't feel comfortable for that, then you need to go into a different, you know, expression of your particular medical field. This isn't going to be for you. So nonetheless, we have practical obligations. They're based on various internal goods that you have, which would include patient advocacy, autonomy, empathy, all those things, right? Like, why are you in this? And then those things, you know, they kind of form practical obligations. This is what we expect of the nurses that are in this particular institution. And the whole thing becomes then a practical ethic. And this practical ethic, at least you can get it now, is going to be a little different than probably your own moral standards. So we can't always just take our personal moral standards and expect those to be the way that we govern how we act in our professional life. Each profession is going to have the standards. We follow those. Ours might be greater than that. And maybe you have a chance to activate those things as you move on. I think I shared with you that when my father-in-law was in the hospital, there were 3 nurses on this floor that I remember, and my mother-in-law was particularly attached to one of them. She just, they meshed. She almost was talking to a friend as she's leaving. She goes, I'm going home now. Okay, Louise, you take care. You're going to call me. I have your cell phone number. I'm going to call you if anything. I mean, there was that whole communication. That's not something that it's obligatory. I mean, you know, we have the number on file, you'll be notified, somebody will call. I mean, you know, you could have handled that in a very sterile, professional way without going against the practical ethics. But, you know, a person who has a deep sense of empathy and can almost put themselves, literally, right, to share in that pain, you're going to do something a little bit different. You're going to, and you watch how far you go with this, right? You can't look at every person that's in there as one of your grandparents. It could really take its toll on your heart, but it also doesn't hurt to bring that level of understanding to the situation, okay? So what then gets developed, if you want to call it that, are community standards, and that's what's expected of you. In other words, it isn't what would the hero do. What would a person who is the most, you know, virtuous nurse in the world do? It's what would we expect from, I don't want to say average, but what would be the legal requirement to provide the same level of care in the same circumstances? You know, I was reading this one study where they had said nobody's perfect, so doctors, surgeons, everybody will make medical mistakes. It doesn't rise to the level, you know, of neglect unless it was truly bad. So there's almost a sense that certain medical mishaps are just expected because we're humans. And the bioethicist that I was listening to give this lecture was also a medical doctor. So he said, although we're allowed a little leeway when it comes to medical mistakes, we're not really allowed any leeway when it comes to ethical mistakes. Because there's just none. And what that means, though, is according to the community standards. It's not that you could have done something heroic. Why didn't you foresee that? How could you have not known it's exactly why the person is in pain? You know, in other words, you're not going to be able to function at that level, okay? And I'll give you some examples and such. The legal considerations, In other words, you want to make sure you're doing whatever the protocol is in your given institution. It does set the parameters. And the practical ethics is going to follow whatever legislation comes out, and that's going to change. So you could see these practical ethics changing over time. Where your moral ethics may develop only more fully, practical ethics will change. A friend of mine who was an elementary school principal, and wherever all the principals go for all their training and such, when they would have lawyers come in to give them concepts of how to handle legal things within the school, the lawyers, he said, would always impress upon them, don't pretend that you know the law. Even we, as lawyers, cannot pretend that we know how a judge is going to declare something. So if you think you're on safe ground because you have some impression of how the law is going to treat this, he said, know this, the law is whatever the judge says it is. And that's the safest course of, to move forward. So, even in an instance where there's some sort of, now you're going to have counsel available to you, right? You're going to have bioethicists there. So if there's issues, you can at least bring these people into it. But all I'm saying is the ethics isn't based on what is just basically legal. You don't just want to make sure that what's legal becomes what's ethical, and that type of thing. But the practical ethics follow this. So let me see if I can't give you a couple of, when I say like my own experiences, and then perhaps you can share some yourself. Let's see. And I might. Oh, okay. And I'm using these examples that are fresh in my mind, only a month old. When my father-in-law was in the hospital, at one point he was in there for internal bleeding, and they thought that he had some ulcers that were going on, within his stomach and such. They really couldn't find the source of the internal bleeding. At one point, there's a few doctors involved, right? So you have his GP, you have a kidney specialist, and you have, I guess, the surgeon, and there's also palliative care, and there's a few nurses. And I was only there for a couple times. But at one point, he didn't seem to want to, be aroused. It's almost like he looked lethargic. And they needed to do physical therapy. And the GP was coming in there and explaining to the family, I wasn't there at the time, saying there's no medical reason why he should be this lethargic. I know he's older, but if you're going to recover from the surgery that he had, we've got to start worrying about physical therapy. So the families, come on, this and that. That night he crashed, right? What they found out was that he had perforated bowels and such else, and there was real reasons for that. And even my wife, who was there, said she was trying to explain to the physician that he was never a really physically fit person for the last 5 years. At his age, what you were requiring to do in PT, I'm not quite sure he would have been able to do that before he came to the hospital. So what exactly? So, what happens though is that the doctors are in or out. They're fully competent, but they're in and out. The nurses become the advocate. So at one point, when we're there, the kidney doctor came in, and I was there, and he was explaining that, look, it's been a couple days after the surgery, it's likelihood that we're going to have to go on, put him on dialysis. Now, we don't have to do that. And if you don't want to do that, of course, we'll keep him comfortable. But obviously, lack of kidney function is not compatible with life. Well, I remember saying, well, isn't that kind of jumping the gun here? And I said, first of all, he's not really responding. We don't know exactly. Not that you can refuse, bioethically, you can refuse dialysis, but he might be able to tell us what he wants. And we don't know at this point whether he's not responsive because of the morphine drip and a day and a half out of surgery, or whether this is going to be a permanent situation. So, the nurses are the ones that are on the floor all the time. So you can, and you're the ones that are going to be able to see. And this is, I guess, one of the backgrounds. It's a performance art. You're going to get a feel for it. And it just takes time to develop a particular sense. I know it sounds hokey when you say that you build an intuitive sense, but you really do, all right? Okay, so in philosophy, I teach epistemology, how you know things. There's this epistemological method that's basically, it's like an innate sense. I won't go into talking more about it, but let me give you an illustration that might help you here. In World War II, England had plane spotters who, for some reason, just some of them were just very good at what they did. I mean, they could tell you whether there was friend or foe before anybody else could, even with binoculars. So if you want to train other people to be able to spot the enemy plane, you get the people who are that good at it. But they had no way to transfer this type of knowledge. They couldn't figure out, well, if they're so good at it, they couldn't articulate why they were good at it, and they couldn't explain it to the next person. There's also this thing called chick sexting. So think of little chickens, right? So you want the females for the eggs, and the males, you discard them. So nonetheless, you can't really tell at that young age, which one am I looking at? You know, there's a vet and such, but it's almost impossible to just say male, female. The people that are really good, they call them chick sexting masters. They just kind of like know. They're right almost all the time. If you ask them, how do you know? I don't know. I just know which one it is. So what they found, it's not just through like behavioral type, modification, but they can get somebody in, because they had the same problem. They couldn't articulate how they knew, nor could they transfer this knowledge. So what happened was they wound up bringing people in and trying them out, and then the sexting master would literally sit behind them and affirm them when they were doing good. And over time, some people were just able to develop the same skill. And they couldn't figure out how they developed it. And they couldn't explain to somebody else how they knew. Okay, so it's not irrational to say that a person builds an intuitive sense on how to gauge these things, right? So over the course of your experience, you wind up getting a feel for, is the non-responsive patient, is it due to some post-op thing? Is it, pain med drips? Or is this person having other cognitive issues? I mean, you start to get the sense for that, and my guess is that the physicians are going to rely on how have you observed this patient. And you can't just systematically say something. It's almost like they're asking for a judgment. What's your interpretive sense of this? And when I say it's a performative art, what I mean by that is you get good at it. And so the minimum standards would be that you don't have to be good at that. I mean, if we're going to go back and just say the obligatory practical ethics would be, is that, in my observation, he's been lethargic for the last day and a half. I realized that he came out of post-op. Usually they're good by now. I mean, that might be all the information, not just legally, but that ethically you're able to give. But a person who really wants to take it seriously, they're going to try to come up with something else, right? And that's what you develop, that type of skill, if you want to call it that. Well, I think you could call it that, right? So we're moving beyond that. Short and sweet. Any questions on that? It's nothing too fancy, right? I want to talk about cultural sensitivity. And anything you guys have to add? I'm always looking for new stories. You saw the other bio that says here, so if I can share something, right? So the way your text defines culture isn't a half bad way for us to use it here, right? So whatever the patterns of behavior are, and these patterns of behavior could be, let's add socioeconomic, race, creed, ethnicity, country of origin, age, right? How do you deal with an older person compared to a younger person? If we don't build some sort of skills to be sensitive to this, then it's going to be an obstacle to healthcare. And again, this is going above and beyond your obligatory. You're not going to, even if you, this is, yes, it's part of patient advocacy, but patient advocacy isn't going to, insist that you're able to ferret out every little nuance that's going on and trying to get to the bottom of things. We'll talk more about that in a second. And I'm going to give you some examples. The problem is nobody can be so astute that they have garnered the nuances of all the languages and how the language may be misinterpreted in English, if this is where we're, practicing. All the variances of cultural expressions, ethnic, just go down the line. How could you possibly do it? So your book had a few, right? It had the Asian nurse who was reprimanded and started giggling. And, okay, if that's true as it is, you would have typically that would be interpreted in the Western mind that you're not taking this seriously. Why are you laughing? My daughter has a nervous giggle. And she's going into nursing. And it's almost like when she's in a very awkward moment, when something's bad, she'll laugh. And I remember telling her when she was in high school, I understand that that's not why you're laughing. So don't hear me like I'm reprimanding you. But the world won't interpret it like that. They're going to think what aren't you getting here, right? Okay, so what do you do when something like that occurs? Or you read the story about the Muslim individual who wasn't quite sure whether there was pork products within the insulin. Well, you don't approach that by saying, what's wrong with you? You should know that. How do you approach these type of things? The problem is you can't know everything. I was reading a study, and actually one of the students in the last class saw it. There was a man, a family immigrated from China, and the father did not speak English. They were bringing him into the hospital for surgery, and it was, all surgery is risky, but this was like one of those, was a little higher risk, but it's not like an uncommon one. And as they were bringing him to the 4th floor, he started throwing a fit. He tried to get off the gurney, holding the door. They couldn't figure out what's going on. Why is this individual not allowed? Is he trying to deny service? What's going on? So they found a doctor within the hospital that spoke Chinese, and as soon as the guy didn't have to go and talk to him, as soon as they told him that where they're bringing him for surgery, the Chinese doctor said the 4th floor, 4 sounds like death. The language is that similar, and it's association. So I had a student last semester that told me that's exactly right, Professor. They said, like here in the United States, you might have some buildings that don't have a 13th floor, right? She said in China there's some buildings that don't have a 4th floor because of the same language. How could you know that? I mean, there's no way that you can know all these things and all these nuances. And part of one of your internal goods is to de-escalate situations, right? Like remember that scenario where the woman wanted to stay with her husband in the ICU, and the nurse was saying that's not typical for here, and she was explaining, but if I go and he wakes up, it's going to affect health care, that type of thing. Well, how do you read those type of situations? How do you get pretty good at this? The reality is it's through education and experience. You're going to develop these things, just like people who develop innate senses to have an intuitive sense of how to figure out the chick or which planes come in. You tend to get good at this. But education is also important because education is supposed to be, how do you want to say, condensed experience, right? So when you hear people say, well, I wouldn't go to somebody who didn't share my particular issue, how can they help me if that never happened to them? Well, is that the foundation we use to determine whether or not we're going to use an oncologist? Do you have cancer? Do you have cancer? Nobody's going to say something like that, right? You're expecting this person has had enough experience with others who have cancer that they can help you. Yes, it's always best if we go through the things ourselves, but you can't experience everything. So education is supposed to try to fill that gap in. I don't watch boxing, but if anybody watches boxing, usually the coaches don't look like they themselves are boxers. Half the time they're shorter and don't look like they can, punch their way out of a wet paper bag. But they must know something about boxing because they're good trainers, right? So, the more experience that you have and the more education that you have in the ethical issues that might arise, the better you are. But there's still something else, right? That's not all of it. This is the goal. You just have to avoid prejudging. Don't assume that you know. If that elderly Chinese man is throwing a hissy fit, don't think it's simply because he's old and lost his mind. If the Muslim's worried about whether or not there's pork products in, don't just assume, what is this? How backward is this individual? If the young girl's giggling because she's been reprimanded, don't just assume she's being inconsiderate. I mean, don't start there. That's really the only thing you can do. And I'll give you a personal example. It's nothing to do with medicine, but when I first started teaching, like 15, 17, 18 years ago, whatever it was, I was in a high school, in a small Catholic city school, and we had the full gamut of socioeconomic students. I'm telling you, we had students whose last names were on the local libraries at the colleges. I still see one of them over at St. Joe's, right? That's how much money we're talking. And then I had other students who, quite frankly, lived in a one-room apartment with their mother, and their mother did things that the mother should not be doing. I'll leave it at that, right? Full gamut. So I always treat people like adults. And even, if they were juniors and seniors in high school, because the way I look at it, my father was already fighting World War II when he was 16. If you're that old, you can stand up for yourself. So if I see them sleeping in class, I don't stop. Hey, what are you doing? Make fun, nothing, right? I've learned that over time. Even if you're thinking in the back of your head, get a mental reserve to at least have enough wisdom to keep your gap shut until you work through something. So when I saw the one kid who I knew had more money than I'd ever seen in 10 lifetimes, sleeping all the time, finally I grabbed him after class, what's going on? And he's explaining about what's happening in his family. There's divorce, so much fighting going on, I can't even sleep. I'm also in lacrosse, I'm trying to keep my grades up. You know, I'm going from one house to another each night, it's just fighting, fighting, fighting. Okay, now you can sort of see this guy's in turmoil. So but I also can't just say, well, we'll forgive assessments. It's not just. That's not how the world works. It's not tough love. That's just the reality of the world. So it's like, look, you know, you're going through a real tough spot here, but this isn't going to go away in a week. What are you going to do? I can be flexible with you. So, you know, there's some deadlines and such. Let's work around those. If you want to hang out after school, we can talk about some things and try to work through some of your, you know, whatever's due. You can do that too. But I only have flexibility up to X. I can't, you know, just dismiss assessments. I had another kid who was sleeping all the time. And this kid I knew was not poor. Related to that. I knew he was poor. I knew where he lived about in the city too. And I said, hey, what's going on? And he's telling me, he's like, look, me and my brother, my mom, she's a single mom, she can't really work. So me and my brother, we work from 5 o'clock at night until 11 o'clock, and then I gotta walk home, and I'm tired. By the time I get home, he says I make some beans and rice, and then I have to study. And then I gotta get up at 5:30 and catch the bus at 6 o'clock to get here. You get it, right? I mean, that's why the guy's sleeping. All the same story. I'll be flexible with you, but this isn't how the world works. I mean, that's not hard law. You go to a job like that, you're gonna lose your job. You gotta find a way to make this whole thing work together, right? Now, talking to other teachers and stuff, because, you know, nobody just sleeps in one class, right? And this isn't, I'm not trying to make myself look magnanimous, right? But you could just assume the rich kid don't care, because what does he care? His parents have money. You know, I don't need this course. And the poor kid, lazy. And you can start thinking like that, right? But you don't make any prejudgments. It's like the whole thing starts out by saying, I don't really have any information, and I'm not going to go by what I'm looking. You can't make certain assumptions, right? And if you could do that in medicine, that's going to fill the gap in where you're lacking education and experience. Just don't act, ask. And if you could start at least doing that, at the very least, you're going to gain more experience, right? Which then brings me to these, this point that I'll make another aspect of this. Find a way and consider it one of the professional skills you need to develop to build some sort of ethical sensitivity. Socioeconomic issues. I was talking to somebody, he's in the family. He has no money, is working labor jobs, and could afford insurance. Now, I'm on Affordable Care Act. If anybody else is on Affordable Care Act, it's not affordable. I'm not here to make fun of anything. It's not affordable. Now they took away the penalty, but it was at the time, if you didn't have any insurance, you had to pay a fine for not being covered. So that's insult to injury. Not only can't you afford the insurance, but now you're getting charged for not having insurance. And that was him. So when he goes to the doctor, this particular doctor, he just see, according to his view, by the look of him, and said to him 3 times, and I'm hearing this at least firsthand from this man. He said 3 times, he told me, you look like somebody who wouldn't be able to afford insurance. Can you imagine? You think the stuff that's involved, it goes on all the time. I remember, okay, so my wife now runs the art studio, right? Years ago, I mean, I still work there some nights and at least in the summers. And when I'm not, you know, dressed up, my hair's down, I got old clothes on, clay all over me, you know, I'm working in the studio, and I had to go get a tooth extracted, you know, because it was just cheaper. And I go up there, and I'm not changing to go to the dentist. This is how I'm going, right? I'm get dressed up for that. So I go there, and my dentist says, well, you know, I have an oral surgeon in here, but he's only here on Tuesdays. He said, fine, I'll come up on a Tuesday. I go up there, and I'm all in these clothes, and probably dry clay's picking off me. The guy says, okay, I'll look at it, I'll be back. Is you prepared to pay today? I said, I'm prepared to pay today. He must have asked me that 3 times, and then left, and then came back, just to check to see if the pain medication's taken. It really wasn't. Just so you know, I'm not in this office all week, I'm only here on Tuesdays. I said, yeah, that's what they said. So you prepared to pay today? I am, because I need payment before I leave today. Okay. Now, he asked me that 3 more times, and I don't have that kind of patience, right? So I literally stood up, and I knew what it was, I called ahead, how much it was going to be. I I put $150 on the counter, my credit card and my check, and I said, what the hell do you want? Let me pay up front? And he said, I'm just trying to let you know that I'm like, I knew what it was. I looked like I was just some laborer that probably didn't have any other, I don't have dental insurance, so he knew I didn't have that. You know, if you would just ask a couple questions, you know, by the way, how would you pay today? Would that be a different way to ask, right? Well, how would you like it? Cash or credit card? Credit either way. I think at that point you'd have been satisfied if I were him. Or just, you know, you're not just somebody that's like, you know, laying alongside the road and crawl in there to get your tooth extracted. You know, who are you? Well, I do this. Oh, okay. You know, it's like, so it's just stop from the prejudging. But it's hard for us. You know, we all like to think we're entirely free of prejudice, but that's not even the thing. Hopefully we are free of prejudice. But the reality is that you cannot be ethically sensitive if you don't have generalizations about groups. How could you? Right? So a friend of mine once said to me, would you be offended if because you're Italian somebody says you like spaghetti and meatballs? I said, I wouldn't. I said, but you're probably not better off to pick somebody else and say, you're Italian, I bet you like spaghetti and meatballs. But if you're having dinner and 10 Italians are coming over, you better have spaghetti and meatballs. It's a safe bet, right? So the difference between, you know, generalizations and stereotyping is generalizations are what we would assume from general populations based on observation. They don't have to be negative, they're just observations. The stereotyping is because you belong to a particular population, you have those. That's the problem, right? So, you know, if you're starting to sense that an individual is not getting something, if you're explaining about the insulin, you might have to have a generalization, which would be valid, that Muslims are going to have an issue with pork pie. I don't know how you're going to figure out how to get to that point, right? But you're going to at least be able to get to there. And if you start out by just thinking that they all are on the same plane as we are, and it's the same culture, we're not that monogamous, you know, we're not that. We're not that homogenous, okay? So, do we understand the difference between stereotyping and generalizations? Generalizations are just what's necessary.
Can you explain stereotyping?
Yeah, stereotyping would just be that you assume because somebody belongs to that particular group that you generalize on that they possess those characteristics, all right? You know, they'd always say, like, if you turned down an alley and you saw a bunch of people in, you know, in leather and on motorcycles, and the other side of the alley had a bunch of people wearing three-piece suits, and you only had two choices, where would you go? Well, I know a lot of bikers. They're some of the nicest people I ever met. I know a lot of people in three-piece suits that probably take you down quicker than anything. But you're going to have to make certain generalizations as you move through this. The whole point of this isn't trying to make a big point out of it. Only that in order to build ethical sensitivity, how could you do that if you don't have some understanding of a particular culture? And the minute you think you have some particular understanding of culture, you make generalizations. There's nothing wrong with that. You have to do that. You just have to move out of that and make sure you're not stereotyping the person in front of you. Having some sense of their culture, their ethnicity, their socioeconomic status, right? Like you always hear, a few people that I know that came from the deep south tend to think that everybody believes that they are stupid because their cadence is slower, they talk slower, that type of thing. You know intellectually that's not the case, right? So just because a person talks slower with a cadence and maybe doesn't have a quick answer like somebody you might meet up in Manhattan or something, you don't assume that one person has a different level of intelligence, right? That would be prejudice. But it wouldn't be, and stereotyping, but it wouldn't be a half-bad generalization to think this is the person's mannerisms, right? That's typical for somebody from the South. So with the language barriers and consent, then you can only imagine what would happen if you're in a moment where some decision has to be made and there's nothing you can do. So when my mother, and I won't go into the whole story here, I'll use part of it when we talk about end-of-life issues. When she was moved from the ICU to a regular room, I wasn't quite sure why. I had not asked for DNR on her because, you know, first of all, with DNRs, we all know they're not ironclad. I mean, just talk to anybody. If a person says and they're adamant about their DNR, their parents or children could just override it. It's that simple. people change. Sometimes, you know, the doctor may not be entirely aware of it, that type of thing also, how it's applying. You talk to the average person, we'll call them the lay person, and they're like, well, I don't want to be on a machine. Pull the plug. They act like it's, you know, this is your choices, right? But there's so much more complex situations involved. So, you know, my mother, when she went in for her first surgery, she had anal fistula surgery and such, 50-50 chance of making it, almost a perfect chance of making it through the surgery, but a 50-50 chance of, you know, surviving it through a week plus, because sepsis is such a big issue. If you put that through a search engine, how many people die from sepsis each year? It's insane. It's like 60%. I mean, you can't even believe it, right? When they eradicate that, of course, it's always an underlying condition. There might be other things anyway. But that being said, so at some point, you know, we determined that this was a life-saving procedure. So she did it, went through surgery perfectly fine. She seemed to be okay. The doc was talking about a DNR, and I said, well, I'm here 3 times a day. I don't see anything imminent, so could we just leave it? There's you know, none right now, and I'll just be her advocate. I wasn't there with power of attorney. They moved her into a regular room, and then, you know, as nurses, anytime you're transferring patients, you have to do the body check, so they're running down all the wounds and whatever. And when you get older, your skin's almost like paper. I mean, it's weird, like you almost like see the veins underneath, right? You can bruise them just by turning them and such. So while the nurses are all doing that, I left not out of modesty because I saw everything with my mother taking care of her for a little while, but I just thought I'll go in the hall and let them get out of their way. And I see my wife going like this. And I ran in and I realized she's in septic shock. So the nurse immediately calls code, and in comes the team, and there's 3 physicians, and there's already 3 nurses there. The 2 physicians and the 3 nurses on my mom, and whoever his position would be, the head doctor comes over and speaks to me and says, you know, we have to intubate her to have her survive through this. The chances of her, we can intubate her, and obviously she would live, but the chances of her coming out of that are, in our experience, almost nothing. And you would have to then make a decision to terminate, you know, life-giving services later. I just said as calmly as possible, I'm a bioethicist. He goes, you understand? I said, I do. And he turned around and said twice, do not intubate, do not intubate. Okay, here's my point. I knew, with my knowledge of the situation, what's going on, how intimately I was involved with this, how hard that was, right? I mean, I knew in the back of my head there was a 0 chance of her ever coming out of the incubator, and it probably just made the decisions harder going on. But in the back of my head, this is mom, you know, as long as there's life, there's hope. Think of somebody where there's a language barrier, or they don't have that level of understanding of what's going on in the room, and you're trying to communicate something to them. Like, we'll look at some scenarios where you have an individual, I don't know if we'll get to the second one today, where these are all real case studies of an Hispanic couple that didn't want their child's, they wanted their child's life-giving, like the oxygen and stuff removed, but they didn't know that meant that they would die. So it's like you can't just hear people's responses and then assume that they know what's going to happen. You need to work a lot of these scenarios out. And my point is when you're in the moment, it's very difficult, right? Now that's an extreme, but you can go to all the various practices that you'll have in your future nursing career, or whatever career you're going to. Think of how, you know, difficult it's going to be in the moment, right? That type of thing. Any questions? Okay. Let's do a scenario. You know who the Amish are? Okay. So baby M, 4-month-old female, and the parents are part of the minority Amish group in a larger community in central PA. And they don't have health insurance typically. And if you know anything about that and health service, you get charged more when you don't have health insurance, right? Because the health insurance companies can negotiate down. If you don't have health insurance, they charge you more. Let that one sink in, right? So baby M's family does not have health insurance. And in case of health care costs, if they're extravagant, what happens is they just basically have community aid. So in their little community, they'll talk to their elders and their bishop, and they'll determine, hey, we have this much money available for this life-saving procedure, right? And oftentimes, like there was one fella near me, his son had leukemia in his 20s, and the father had spent so much time with the Amish that the Amish, it's kind of like a barn building thing, but they did it with fundraising. They put together this fundraiser just to raise money for his treatment. And it was kind of inspiring, all their cake goods and quilts and everything. So it's not, this is I'm sure, a true scenario. Okay, so they are not adverse to Western medicine. They're not backward. They may be uneducated, but they're not unintelligent, all right? Going to school to 8th grade doesn't leave you with a lot of higher education, but it sure doesn't mean that you're not a smart person. So referred to the cardiologist, baby M, partly because she had trouble breathing, so Dr. Tolland says, I got bad news. The child needs open heart surgery for a valve replacement. Without the surgery, this baby will probably die soon, within the year. So let's just keep it simple and say that's certain. We know this child will die within the year. With the surgery, though, we expect full recovery. However, nothing's without risk. So there is a chance that baby M could die, or maybe, there'll be some other damage that's done during the surgery process. But the physician assured the parents that the outcome was certainly in baby M's favor with the surgery. So even though the physician expected the parents to accept the surgery, they made and attended the appointment because, they were there for everything. They showed up when they should. They listened. They just said, we don't approve. So at this point, you can imagine he's probably like, okay, now what do we do? So what do you think? What should Dr. Tolland do? Tell the parents they're risking the death of the young daughter, or question the family about why they don't want the surgery? A or B? We're gonna say B, all right? It's not that A is not a concern, and it's not that this is what you're thinking, but it's probably not the best initial approach. It could be confrontational, and it's also, this one already assumes that they don't understand that. We're not there yet. In other words, just because, and he doesn't know a lot about this sect, so he may not know that these are not unintelligent people. They're just maybe not educated, but that doesn't mean the same thing. So at this point, you got to ask questions. Why don't you want the surgery? All right. Even if like somebody in the last class said, yeah, but wouldn't you eventually get to that? And I said, maybe. We're trying to say you wouldn't start there. And when you do these types of scenarios, and if you see one in an exam, don't overthink it. If you're overthinking it like that would be overthinking it. Well, I might eventually ask that. That's not the way it's posed. What question would you ask if you had these two choices, right? You would go there. So we're going to ask, why don't we want this surgery? So that's how this then ensued, all right? Well, at first, Dr. Tolland simply said the risks were low. And he didn't really give them a numerical value. Was that proper? Like, he didn't tell them. He just said it's a low risk. Do you think he should have said it's 1%? Or something like that.
Thank you.
See ya. Okay. Yeah, B. You're going to have to find analogies to work. And remember, these scenarios are not game shows. You don't have to answer when the buzzer goes off. You're in the middle of a lot of things. You could, if you're part of this conversation, and I get it, maybe this is the position, but let's pretend you're part of this conversation. I'm going to talk to you about this. I'll be right back. I have to go and do this. What analogy can you use? Like if you want to give a 1% analogy to somebody to help them figure this out, you're going to start brainstorming. If you had 100 pieces of candy and one was like bad, like it really tasted bad, and well, it was only 1 out of 100, and you told somebody, do you think that's a decent chance of you getting that bad piece of candy? I mean, you're going to have to give them something, that they can start to understand it. You can't just assume, that when you say a 1% chance, and people always invert statistics in their mind. What, is it 1% for what? For survival. You mean they have a 1% chance to survive? No. They have a 1% chance, that something will not go bad. They have a very good chance for survival. It's not hard in a moment for people's minds to get intertwined on these things. So it takes time to work all these things out. And the whole time, you're trying, again, with its ethical sensitivity, you're trying to ferret out, why are they not understanding this? Try to put it on the back burner, the judgment. Why aren't they understanding this? And ask yourself, why aren't they understanding this? Like, how can I do this, right? That type of thing. Okay. So Dr. Tolland at this point is still confused. So when the parents understood that the odds were good, well, once he explained it, he figured they're just going to go on board with this, right? When they didn't, now he's getting angry. And he's thinking, this is like nearing child neglect. You're going to allow this child certain death rather than a 99% chance of survival? He thinks if I see a court order, I'll probably get treatment for baby M, because he knows there's precedents that have happened with Jehovah's Witnesses that have refused, blood transfusions, or if they have surgery, there's bloodless medicine techniques and such. So he knows that the courts have upheld those, and he's thinking, I got that, right? So what do you think he should do then? Should he tell the parents that what they're doing is medical child neglect and explain that it's not going to be tolerated by either him as a doctor nor the courts? Or should he explore their reasons for rejecting treatment? Okay, there's no lawyers here. They're going to say, I'll take the case, right? Yes, that's always an option, but it'd be like a nuclear option at this point, right? It's not where you're going next. You're still not quite sure. You've got them to understand that the chances are pretty good, and you thought that was the obstacle. In other words, you thought they didn't understand that the chances are good, therefore accept it. Well, now that you realize they understand that and they're still denying it, the next thing should be, why? There's got to be something else that's going on here that we're not quite getting. So he controls his anger. He inquires about their reasons. And they claim that they've spoken with their community elders. And typically they reject such treatment. And they've recited other examples. But those examples are always involving older people. So they're not sure that they apply. And they sort of believe that this treatment's against God's will. Now, if we stopped it there, you might be thinking they're fetistic, right? I mean, this isn't, what do you mean? Like there's some fateful thing that now your child's sick and it should be allowed to die? But they continue the conversation. Dr. Tolland asked the parents whether they would permit a hospital social worker. So now he's thinking, I can't go any farther, and maybe he shouldn't, especially if he's got some anger issues. It's gonna flow out, right? I'll let the social worker go and talk to the elders, and he even said, we're not going to bill it. So, in other words, anytime you're in a situation, you take away as many variables as you can. We want one variable, a social worker, no money. That way we don't have to think, is this a money issue, okay? So the social worker goes and to hear everything they're going to say. Dr. Tolland then consults with the social worker, Ms. Lattimore, who agrees to talk. And they claim that, when the child's involved, the prognosis is good, they would support the surgery. However, $100,000 for the surgery is just a little bit beyond their resources. And they can't, as a small community, pull together that much cash. So now you're starting to see this is really a money issue. This really wasn't about them not understanding. They weren't stupid just because they had a lower education. Ms. Lattimore talks with the parents, and they continue to reject the treatment, even though they understood the elders would support it for the child. In other words, they have a sense of, indebtedness. And we don't want to be this level of burden to our community. And they kept centering on the fact that our community cannot afford that. We're asking too much of our community. And the parents continue to adamantly reject the surgery. So Ms. Lattimore goes back and talks to the officials at the hospital, and they say, we'll subsidize this. How about if we can break this down to $50,000, which is probably what it would cost or less if they had insurance, right? That's the crime in all of this. She talks to the elders, and they say, we'll do that. If you can keep it at $50,000 and it's only a 1% chance, that the child will not survive. We think that that's, it's in the best interest of the child and our community, so the parents agree to the surgery. I'm going to ruin your day. The surgery was performed. Unfortunately, Mrs. Baby M died. I didn't create this one, or I wouldn't have been that cruel, I know everybody was cheering for Baby M here. Now what? Could you imagine that? I mean, okay, it's not it may be an extreme, but it's not an unrealistic scenario. These things happen, right? People die from all sorts of. A friend of mine, his mother went in just for a hysterectomy. How many hysterectomies are done? She never came back out. I mean, so these things happen, right? Now what? Could you imagine explaining that one to the parents? So what do you think? Does the death of Baby M indicate that they made the wrong decision? I mean, we're just adding more pain and grief to this poor family. Now they've lost a child and $50,000. Yeah, it's B. It was a better choice. Okay, how'd you know, right? But hindsight's not how we work. We work with what we have going forward. And if money was the obstacle, and that was overcome, and the percentage was so low, this was not a choice that should have been that difficult to make. Certainly not ethically. It's just a shame how things turned out. But let's go this far. Let's say that even after you knocked it down to $50,000 and the elders thought they might be able to fork that kind of cash up, but they're not sure and the parents are still saying no. Now what? Do you think that Dr. Tolland and Ms. Lattimore should have went to the court to force a treatment? That's a horse race. Not anymore. It's A, yes. Those odds are just too good at some point, because it's certain death. It wasn't like this child may be disfigured, or this child may not develop, physically well. It's a life and death situation. It's all likelihood a bioethicist would have been brought in, they would have went over this stuff, and then this would have went to court, right? And probably once the judge heard that you reduced the fee and a 1% chance, he would have said, as opposed to a certain death within the year, he said, no, now you're not making. In other words, do you see how there's limits to autonomy? There's limits to patient's advocacy, right? They're not absolute. So at some point, intervention has to ensue. Okay. This goes to 315? 345, I'm sorry, 345? Right? Okay, let's do one more then. I didn't get a chance to do this for the previous class. All right, Mr. and Mrs. Gonzalez, they're committed Roman Catholics, and they believe that their religion demands all efforts made to preserve life. Unfortunately, the newborn child suffers irreversible brain damage and was determined to be in a persistent vegetative state. The staff believed the best course would be to remove the infant's ventilator and just allow the baby to die peacefully and naturally. Nurse Jones, though, objects, claiming that it's illegal in the United States to remove the ventilator, even with the permission of the parents. The staff rejected her view, so they call in a bioethics consultation. What do you think? A newborn child in a permanent vegetative state, can they remove the ventilator? Do you think it's legal to do so? Yes, in the United States, federal baby donor regulations prohibit it, or no, federal regulations permit removal of aggressive treatment when the infant is chronically or reversibly comatose. Okay, it's B. All right. Now we didn't go over this, so there's this difference between what they would call ordinary and extraordinary care, or often now is referred to, maybe in the medical field, some places they'll call it ordinary and extraordinary. Typically in philosophy and bioethics, they'll call it proportionate and disproportionate, because what's ordinary changes. So if you call something ordinary and extraordinary, that will change as procedures change. But proportionate and disproportionate could always be ethical applications. So if the child being kept alive and it's been determined that the child, is irreversibly brain dead, then to remove the ventilator would not be disproportionate. All right. So it's B. Now, the hospital bioethicist explained the law to Nurse Jones. She accepts his opinion about the law, but she still claimed the removal of the ventilator was immoral because it would destroy a human life. Now, be very careful of the terms. I didn't spend 2 days trying to talk about human life and person, for no reason. Those are 3 terms that always have to be kept clean. Other members of the staff expressed strong disagreement with Nurse Jones. They said that life in a PVS was no real human life at all. And the removal of that ventilator was the humane thing to do. Just from a philosophical point of view, I'd already be taking apart this paragraph, right? I mean, the language is so loose being used. This is where my wife would turn in and say, you know what they mean. It's like, no, you got to use the words to mean what they mean. But nonetheless, all right. Suppose the parents agree to move their ventilator. Do you think it's appropriate to ask Miss Jones to do it? I mean, she works there. Is that enough? Or should you respect her views? Remember, here's where you're going to have a conflict between your own personal morality and your professional obligations. So let's see. It's B. They could find someone else. At some level, individuals should be allowed to work within the realms of their own conscience. This is an extraordinary case, and there's other people there. If there was something that was ordinary within the course of what would be ethically obligatory for the nurse, then maybe rethink your profession. But there's no reason why they can't just simply go get somebody else to do this, right? And not make her go against her own conscience. There's not always conscience clauses in certain things. I think it should be, right? But there always isn't. Now, is a person in a PVS alive or dead? Your choices are, they're alive. A person in the PVS has partial brain function and therefore legally at least is not dead, or they're dead. In such a state, the person has no cognitive functions. This means that no real person exists. Okay, just the term person ought to throw you there. That's the theological and philosophical application. No medical analysis can determine personhood, right? That's a lot, human and life. In most states, a person, even with the cessation of brain activity, will still be considered a human and alive, all right? But remember, this is where we are going to struggle, in whatever views you had on personhood and how you apply it at the beginning of life and the end of life. Is that really Uncle Joe? Is he really there anymore? We start to talk like that, but are we talking about whether or not that's a person? And even if it was a person, that doesn't mean that something can't happen from here, right? Just because even if you designate them as a person, doesn't mean that that person has to be kept on a ventilator for the next 30 years. That's not necessarily true. But it's just getting it right. And what I liked about this was because I went farther than your text went But then this came back and affirmed it. So I wish they would have talked more about personhood in the text, but at least with this case study that I pulled from it, they affirmed it. Okay. Now, they resolved the legal issue. So the attending physician talked with Mr. and Mrs. Gonzalez. So what they didn't realize was upon hearing what it meant to remove the ventilator, see, they weren't putting that together. When they were asked, can we remove the ventilator, they never interpreted that as the baby's going to die. That was not how they were putting it together. They insisted this would kill their baby. And they said God would damn us to hell who deliberately killed their baby. Now see here, the cultural sensitivity, if you're Catholic, you know that that's not true theologically. But we're not even here. What does that person think? That's where you're at, right? I mean, it's what do they think their beliefs are, that type of thing. So now what should you do? They just said, well, don't remove the ventilator because we don't want to get damned to hell because we should do everything we can to save our baby. Should you accept the view and tell them the ventilator will not be removed, or respectfully inquire about the basis of Mr. and Mrs. Gonzalez's belief? We're going to go B here. We're not ready for anything else. At this point, it's likelihood there's some misunderstanding that's going on. You're not quite sure. Because especially Catholicism is not an obscure, faith expression in the United States. So there's going to be enough people within that hospital to think that there's something else here, because that should not be the issue. So what's going on here? Even if that's what the people believe, right? So the attending physician spoke in a consoling way to Mr. and Mrs. Gonzalez, expressing his understanding and sympathy. And they responded to this and explained how much they wanted their first child. And again, with compassion, the attending asked why they thought it would be wrong to turn off the ventilator. And the couple said that that was giving up on their child, and that the child was only a few days old and they would soon come out of the coma. You see, they were thinking that they didn't know what a PVS was. They thought the child was in a coma, and people come out of comas. And we thought removing the ventilator would mean they breathe on their own. But now you're telling us you remove the ventilator, they're going to die, but they're not out of the coma yet. I mean, so you're trying to figure out, where is the miscommunication here, okay? So now what does the attending physician do? Do they explain that the child is very unlikely to regain normal functioning? Or do they simply accept the view of Mr. and Mrs. Gonzalez because some people do come out of a PVS? At this point, the attending physician is going to have to start bringing some evidential things to the table. Show brain scans, talk about what's happened in the past, say that, we're not discounting your faith or that there are miracles, but we've never witnessed anything like that. And there's the chances of this happening, something's got to be explained, right? So here, you're going to have to explain in a very compassionate way that, we can't put a percentage on it, but it's almost next to nothing that this child will ever pull out of this, all right? So your hopes that they're going to regain consciousness are not realistic. So what happened then was, after the attending physician fully explained the baby's condition, they accepted now that their child will never regain consciousness. However, they still continue to reject the removal of the ventilator, right? And I've talked to people where not maybe this is a child, but where this has gone on for a long time, and it isn't that the hospital or the doctor are thinking that you're absorbing resources that you don't need to, but it is there. That's part of proportionate care. Proportionate care has to be determining how much does this cost, right? So the physician can again compassionately ask why they wanted to maintain life support. This time, Mr. and Mrs. Gonzalez explained it was against their faith to remove the ventilator, and that caring for the child would be the cross. In other words, this is what God wants us to do, to take care of this child who will never become conscious. They indicated that it had not been for the religious commitment, they'd probably agree. Okay, so now the doctor knows what the obstacle is. And he probably at least has the understanding that they're not interpreting this correctly, okay? So what should the attending physician do next? Accept their view and tell the ventilator not be removed, or seek guidance about the Catholic view on removal of the ventilator for a patient in the PVS? You got it. It's time to call in a theologian, all right? Because their issue is not medical at this point. It's theological. So in this particular case scenario, they brought in Father Garcia. And Father Garcia sat them down and helped them understand the church of position. And though they were reluctant, you can understand, right? First child, they decided to permit the removal of the ventilator. They now thought it was God's will that their baby die, and the couple told Father Garcia that the kindness of the staff, including the attending physician, was greatly appreciated at this terrible time. This could have been complicated by other means, right? If the child was breathing on her own and was only receiving ANH, artificial nutrition and hydration, from a Catholic standpoint, that would change the scenario. Because typically, nutrition and hydration are not considered, from a Catholic moral standpoint, medicinal, treatment. It's just food and water. It doesn't mean that you keep it in until the end. So, I mean, even you guys know, or will know, that even a person's ability to, assimilate and absorb, or just to port, right? At some point, you can't really, relay this treatment. But if you're familiar with the Terry Shigo case, have you heard that case at all? Okay, it was a Catholic woman who was in a coma for decades, breathing perfectly fine, but on ANH, and her husband, who, I don't want to sound cynical, but at the point where he was getting remarried and had her removed, and he had power of attorney, and the parents fought it and went to the Supreme Court, but they did remove their nutrition and hydration. So that would complicate something like this. But in this particular scenario, this is disproportionate care. It's removal of the ventilator is perfectly fine. Kind of makes sense? Okay. All right, on Tuesday we'll do informed consent, and we'll start looking at how we're going to put together